Hi everyone and welcome back to medibrain. Today's topic is a case study of pyloric stenosis, so let's dive in. Will is a 7-week-old infant who presents to the emergency department with a 1-week history of non-bilious vomiting. His mother describes the vomit as shooting out, also known as projectile vomiting. He has a good appetite but has lost 300 grams since he was last weighed a week earlier and has mild constipation. The family has recently returned from Spain. There is no vomiting in any other members of the family. His sister suffers from vesico-ureteric reflux and urinary tract infections. Will has no fever but is mildly dehydrated. His pulse is 171 beats per minute and his blood pressure 81 to 42 mm per mercury. There is no organomegaly and no masses or tenderness on abdominal examination. Laboratory results show low sodium, low potassium, low chloride, high urea, high creatinine, a high pH, high bicarbonate, and a high base excess. So what is the most likely diagnosis? What is the differential diagnosis? How would you confirm the diagnosis? And what is the treatment? If you want, you can stop the video here and think about it for a minute. In an infant of this age with non-bilious projectile vomiting, pyloric stenosis is the most likely diagnosis. Symptoms usually develop between the 2nd and 7th week of age, which include, for example, frequent regurgitation progressing to projectile non-bilious vomiting immediately after feeding, and an enlarged, thickened olive-shaped, non-tender pylorus, which could be palpable in the epigastrium. If a baby demands refeeding after vomiting, it's also called a hungry vomiter, where the vomitus is never bile-stained as the obstruction is proximal to the duodenum. Furthermore, symptoms could be constipation, hypochloremic alkalosis, which is characteristic and develops after vomiting hydrochloric acid, hypokalemia due to the kidneys retaining hydrogen ions in favor of potassium ions, and high urea and creatinine, which suggests that there is also mild dehydration. We should also mention that the male to female ratio is 4:1 and is more common in firstborn children. If a pyloric stenosis is left untreated, it could result in dehydration, weight loss, and failure to thrive. The differential diagnosis should include a gastritis, but it would occur with an enteritis, diarrhea, and possibly with fever, a gastro-esophageal reflux, which presents from or shortly after birth with poor appetite, and a urinary tract infection, which may be present in a very non-specific way at this age, and it is therefore mandatory to test the urine. And in the absence of nitrites and leukocytes in the urine dipstick, a urinary tract infection is very unlikely. The fourth differential diagnosis could be overfeeding, which could be elucidated from a careful history. And the last differential diagnosis could be a midgut volvulus and an intestinal mole rotation, but in this case we would see bilious vomiting, abdominal distension, signs of bowel ischemia like hematochezia, hematemesis, hypotension, and even tachycardia in severe cases. The confirmation of our diagnosis could be done by a test feed, which leads to visible peristalsis from left to right. During careful palpation, a pyloric mass, which is the size of a 2 cm olive, may be felt in the right hypochondrium. Another test could be an ultrasound in which we see the thickened and elongated circular muscles of the pylorus, which are normally below 3 mm. Two additional signs of an hypertrophic pyloric stenosis are the antral nipple sign, where the mucosa is protruding into the antrum, and the cervix sign, which describes the general protrusion of the whole pyloric muscle into the stomach. As an initial treatment, we could treat the dehydration and the acid-base and electrolyte abnormalities with intravenous fluids. For example, 0.9% saline with 5% dextrose and added potassium chloride, which would be the appropriate starting fluid in this infant with low sodium and potassium levels. Of course, feeds should be stopped, a nasogastric tube inserted, and the stomach emptied. The definitive surgical operation is the so-called Ramstedt's pyloromyotomy. Thank you for watching. If you enjoyed this video and you want to support me, please like and subscribe to my channel or follow me on social media. Till the next time.